Let's start with something that we all know. I think that we all know the dermoscopy of tinea capitis. Okay, in tinea capitis we have dystrophic hair, especially this S-shaped hairs, but also C-shaped hair and band hairs. So dystrophic hairs. Okay, great. Corkscrew hairs. This is another nice finding in tinea capitis. Okay, these are nearly pathognomonic for this disease. Okay, we can do the diagnosis, but now we have to treat the patient. Okay, this patient was treated with grisofulvin for 6 weeks. Okay, on the basis on clinical findings, may we say that this patient is healed? Huh? Yes? Are you sure? No. Okay, let's take a look at dermoscopy. What do we have here? We have just a little bit of scaling, but we don't see the dystrophic hairs anymore. So you are right. She's healed. She's healed. Because, you know, the marker of the active infection is the presence of dystrophic hair. Okay? So see, if we don't see dystrophic hair, we can be confident that the patient is healed. Of course, if we have any doubt, we can do a culture, of course. But I saw again the patient after 1 year and everything was fine. Okay? We still can see, you know, a little bit of scaling. Okay? Because this patient was atopic. So it's normal to see a little bit of scaling. Okay, great. So now, another case. What do you think? She's healed? No? But you're too good. Come on. And do we have any confirmation? Yeah, she's not healed because we can see the dystrophic hairs. Okay? So the corkscrew hairs, the C-like, C-shaped hairs. Okay? So we have dystrophic hairs, so she's not healed. Okay? So we have to continue the therapy. Perfect, perfect. Now, let's move to another disease. What do we think? Yeah, pediculosis. Okay, so topical pyretrins, day 1 and day 10. Let's see the result. Is it still active? Yes, are you sure? No? Is this an egg? No, no, come on. It's a little bit of scaling, because the irritation of the treatment. Okay, so it's dandruff. Okay, so she's healed. We are fine. We don't have to continue the treatment. Okay, here, from a clinical point of view, I'd say we still have needs, but let's take a look at dermoscopy. Do we have needs? Yeah? Are you sure? This is a needs. You can see that, you know, this structure envelop completely the hair. So it's not a knit. This is a hair cast. Because this lady treated her scalp 4 times. So she had an irritation, a very remarkable irritation. So we have a scaling from the hair. Okay? These are called hair casts. So we have to be very careful about, you know, not confusing the knits from dandruff and hair casts. Okay? So this lady is fine. Okay? She's healed. Great. Another case. Still here we have, you know, structures that may look like knits. Let's take a look at dermoscopy. Knit. Okay. You can see that, you know, the knit is light on the hair, but it doesn't envelop completely the hair. Okay. Perfect. So, is she active? Yes. Okay. Okay. Still active? Okay. Actually, we have to distinguish a viable knit from a non-viable nit and an empty nit. Of course, it would be active if we have viable nits. Viable nits are characterized by the presence of this cup, the operculus. Okay? Non-viable nits also have this cup, but the color is different. Okay? Here we have a homogeneous brown color. Here we have some bubbles of hair. So we have a little bit of white. Of course, empty nits are transparent. They don't have the cup. Okay. So for pediculosis pubis, it's the same. Here we have a rave party. Viable nits. Okay. The cup and the color is brown, homogeneous. And then we have non-viable nits. So the cup is still there, but the color is different. They are not, brown and homogeneous. Okay, so let's come back to our patient. So now, no. Why? Yeah, we don't have the cup, and we don't have a brown homogeneous discoloration. Much simple. Okay, non-viable nits, so it's fine. Perfect. So now let's move to psoriasis. I don't know if you agree, but legs are, in my opinion, the most resistant areas when we treat psoriatic patients, no? Often we have, some lesions still there on the legs. But why? Well, I don't know. Let's see. Here we have two patients which are very, very similar between each other. Okay. I treated these two patients with phototherapy. Okay. But in the first case, we had a very good result. We don't have anything, basically. But in the second case, we still have the same situation as the beginning. But why? At the baseline, they were pretty much similar. Let's take a look at dermoscopy of the baseline. This is the psoriatic patients. You know that in psoriasis we have dotted vessels distributed in a uniform pattern. Okay? Right, Nisha? Right. Okay. But in this case, in the upper case, we have dotted vessels, okay, small vessels. In the second case, you can see that we have globular vessels. So the vessels are bigger. So we have two patterns, okay? And the presence of globular vessels indicates that we have, higher hydrostatic pressure, okay? Great. That's the reason, okay? When we have globular vessels, it's unlikely that we have a good result if we treat psoriasis with phototherapy, okay? On the other hand, the presence of dotted vessels is positive, okay? It's likely that we will have a result. Okay. Okay, as I told you before, the presence of globular vessels is a marker of higher hydrostatic pressure. For example, here we have globular vessels, and this is a lipodermatosclerosis, which is a typical disease due to the presence of a higher hydrostatic pressure. Okay, of course, I can skip this. When we have a higher hydrostatic pressure, you know that we have hypoxia and release of pro-inflammatory mediators, and that's the reason the disease may be more resistant, okay? Okay, so I talked about phototherapy. Now, a few words about the association calcipotriol betametazone foam. I did the same thing. So I studied the vascular pattern at the beginning, and then I treated the patients. Here we have dotted vessels, so small and very uniform vessels. I treated this patient, and we obtained a very nice result after 4 weeks. Okay? Great. Because when we have dotted vessels, we may be confident to get a result. Okay, but I'll show you this patient after stopping the therapy, okay? Week 8. We have the same situation as the beginning, okay? But why? Let's take a look about dermoscopy of this stage, when we had clinical healing. Actually, we did not have a complete clearing. healing, okay? Because we still had dotted vessels. So we reached a clinical healing, but not a dermoscopic healing, okay? And the presence of vessels, despite clinical healing, is a marker of possible recurrence. So ideally, we should reach a dermoscopic healing, okay, to reduce the risk of recurrence. Great. Here you can see in the target area, okay, that the patient, after stopping the therapy with the foam, did not experience a recurrence, okay, because here at week 4, we reached also a dermoscopic healing. We don't see dotted vessels, okay? So our aim is to reach the dermoscopic healing. Okay. The question now is, how long does it take to get dermoscopic healing? It's a nice question. I don't know, actually. But we had a couple of patients that came every day after clinical healing, and we studied them. And we saw that we need 1 week of extra application, okay, after clinical healing to get the dermoscopic healing, okay? 1 week. Okay, great. Vitiligo. Very quickly, this was a patient treated with phototherapy, okay? And we reached a nice result, I'd say. Okay. This is the dermoscopic at the baseline. We had a very important finding, the pigmentation around the follicle, okay? The presence of pigmentation around the follicle is a positive predictor factor for the treatment, okay? Great. On the other hand, we didn't find any association about white hairs on dermoscopy and bad outcomes, okay? Which is the reason, of course, of the association between perifollicular pigmentation and a good outcome. Of course, we all know that repigmentation in vitiligo starts from the follicle. So if we have pigmentation around the follicle, it's likely that we will get a result. Great. And also we can say if the vitiligo is stable or not. Do you think that this is stable? This is stable? I don't know. I don't know. You don't know, but it's reasonable. We have dermoscopy to say that. In stable lesions, we have very sharp margins, perilesional pigmentation, and perifollicular pigmentation, okay? In unstable lesions, we have, ill-defined margins, as you can see here, and also this satellitosis and the microcorbner phenomenon, so linear white patches, okay? So, is this stable? Well, chi lo sa? I don't know. Now, what do we have? White globus in, at the periphery of the lesion, so satellitosis. So, it's stable. Is it stable?
1 minute.
Yeah, is it stable? Answer me. It's unstable, of course. Great. And this, sharp edges, perifollicular pigmentation, so stable. Okay. Stable. So this case, I've Nivlitan. This, of course, is rosacea. Okay. Are we sure? Yes, we have, the polygonal purple vessels. Okay. Okay. I prescribed metronidazole, and this was the result. The patient was much more upset than, the baseline, let's say. Okay. But are we sure that we didn't miss anything? We have these protruding follicular plugs, okay? Yeah, which is Demodex, okay? When we have Demodex, it's likely that we have a better response to ivermectin, okay? So, I prescribed ivermectin, and the patient was very happy, okay? I think that I can stop here, okay? Thank you.